physics in a bit more detail. All right, so let's just go straight in. I'm not going to do a physics background. I'm going to bring it out from the clinical stuff. So radiotherapy has been effective for more than 100 years. People often say a lot less. People actually think that it's less commonly used. Because if I said to you, how many people do you think get chemotherapy for their cancer? You might think more, 70, 80, 90, 100. And sometimes radiotherapy is kind of forgotten. But it's a really successful treatment for certain cancers, and it's very commonly used. And so thinking a little bit more about how it actually works. So it works by damaging the DNA of these cells and destroying their ability to replicate. So once again, we're trying to target that cell replication that causes the abnormal growth. So radiotherapy will affect both the cancerous cells and the healthy cells. That's the important thing to note, in the same way as chemotherapy does as well. But the healthy cells can repair the damage, whereas the cancerous cells have less good, they have their what's the word? The things inside the cells that are helping them know that the DNA is damaged. We talked about the checkpoints. Sometimes they aren't working properly. And so often these cells end up not being able to repair themselves in the same way. Now that can be a problem if they've got minor faults. So in the checkpoints, one of the reasons in Tom's lecture that we talked about how cancer can happen is that the checkpoints become a bit dysfunctional. And they're not as good at saying, actually, in that little factory that we showed of the nucleus, they're not as good at saying, actually, this isn't good enough quality to go out there. But if we can, radiotherapy damages them so much that it causes the death of the cells, but damages the healthy cells we want to try and damage the healthy cells to just the level that they can still repair themselves. So it's about getting that level just right. Enough to kill the cancer cells, but enough that allows the healthy cells to still repair themselves. And that's this term fractionation. So that's how we dose the radiotherapy. So rather than giving one massive load of radiotherapy on one day to kill off all the cancer cells, well, that would also kill off loads and loads of healthy cells. So by giving radiotherapy often and little and often, it allows us to gradually kill the cancer cells by getting more and more dosage loading up, but giving the healthy cells time to repair in between the treatments. So hands up if you've known anybody to have radiotherapy. Family friend, family member. Okay, so lots of you. Just shows how common cancer is, doesn't it? But so how often would they have gone for treatment? Once a week? Anyone know? Shout it out. Hand up, yeah? Yeah, perfect, 5 times a week. So they go every day for 5 days to have their treatment. And the idea of that is if you're getting a little bit each day, we're allowing time for the healthy cells to repair themselves. Now thinking about the uses of radiotherapy. So we can cure cancer with radiotherapy, generally not on its own. Generally radiotherapy is used following surgery, for example, to kill off any residual cells that might have been left behind from the surgery. Or they can use it in conjunction with chemotherapy. So it's trying to do that sort of attacking the cancer from lots of angles to try and make sure that we get hold of it. But radiotherapy is also very useful in more palliative stages. So one of the words that I think it looked like it was misspelt, neoadjuvant chemotherapy. That's a specific clinical term for a chemotherapy that's used to try and cure. Adjuvant means we're trying to cure it. And neoadjuvant means before surgery, because you're doing it before you're doing the main curing thing, is how I try and remember it. So adjuvant means to cure, and palliative means we're not aiming to cure somebody, but we're trying to get their quality of life to be as good as possible for their remaining life. And the thing that's weird is that in your mind you might have heard of things like palliative care, which is a term used for the treatment when someone's maybe coming towards the end of their life. But in cancer, so many people actually live with cancer, and they might have cancer when they die, but they haven't died of cancer because we're so good at managing cancer now that it's not as negative as it used to be. So palliative treatments can often be to relieve symptoms in a cancer that, yes, realistically we're not going to be able to cure, but we can keep on top of it, keep the symptoms manageable, and this person often goes on to live very many years of good quality of life. So an example of that would be sometimes people have, it's called bony mets, so it's mets mean metastases, which is just whenever the cancer spreads. So So the cancer goes to another part of the body from where it started. And often that can be really painful. Make sense? So it's both curing and relieving symptoms. I think it's just important because sometimes in medicine we always think we have to cure this. It's like, well, actually, how can we make the person's life quality as good as possible? So this is an interesting one because we've talked a bit about some of the monotherapy, such as chemotherapy. We've talked about radiotherapy now. We've talked about some of the more interesting, in my opinion, but quite cool targeted therapies. And we haven't mentioned surgery much, but it's obviously a very important treatment for cancer, and it's often very important in curing cancer because we can actually remove the cancerous tumour before it spreads. But which order do you do them in? Now, when we first think about cancer treatment, most people always think surgery first, and then follow it up with chemotherapy or radiotherapy to get the remaining cells. I mean, that makes logical sense, right? Sometimes that's not the best thing, because sometimes, can anyone think of a side effect of surgery? Yep, low immune system. Well, yeah, that could be an important factor. But often major surgery, if you were having major surgery, would you be able to run a marathon the next day, do you think? So you often would need to have a lot of time to heal, even healing scars. So if you think about if you fall and cut your knee, how long that takes to heal. It can take quite a while. And so one of the things, what I've done here is said case study, which is I thought it was quite fun. It's like, oh, let's pick something we can focus on. But if we think about cervical cancer, if you have treatment of surgery for something like cervical cancer or other gynecological cancers, which involving the woman's reproductive system, because there's a delay in the time you have to heal, radiotherapy is often not as effective afterwards because the healthy cells are already trying to heal. So do you remember we talked earlier about it's about giving the right amount of dose of radiotherapy that we can kill the cancer cells but allow the healthy cells to still heal in time. If they're already healing from quite a difficult and dramatic surgery, so it's as if you've fallen and cut your knee, all those cells are struggling to heal as it is. If you load them up with radiotherapy, they can then just disintegrate and you end up killing a lot of healthy cells and you get a lot worse side effects. Does that make sense? So sometimes rushing in with surgery first is not the best option, and it's very specific. And one of the nice buzzwords for this you can think about for your medical school interviews, you might have heard of patient-centered care. So personalised medicine is this terminology, meaning we're trying to personalise all the treatments we give specifically to that person, and that tends to mean more genetics. So if their cancer is HER2 positive, then personalised medicine would be thinking, okay, we could give them Herceptin rather than somebody who doesn't have that. But actually, personalised medicine in the general sense is actually about thinking about the person individually. What one person thinks is a normal, something that they can tolerate as a side effect, someone else wouldn't even want to consider. And so it's about working out for this person what is best for them. And so cancer treatment is evolving into something that is very much based on the individual and their cancer. Does that make sense? So it's not just always as simple as surgery followed by the others. Sometimes the order is different. I think that's quite interesting to understand. All right, we've talked a little bit about how it works in terms of the biology/physics of it by affecting DNA replication, but thinking about radiotherapy is given over a series of days. So as we talked about, 5 days of the week. And it is actually painless, so the beam doesn't hurt, but the side effects can be quite painful and can be difficult. So here is a rash caused by someone's radiotherapy. It's quite bad. And so that's caused by the fact that obviously for the radiotherapy to enter the area that they are trying to get the cancer cells, so it depends on where this person's cancer is, the skin's getting quite a high loading dose because it has to go through that. Now they do have ways to try and get around this and minimise it, but it can be difficult. And so you would have creams you put onto this, and they would give you different things to try and help the side effects. So again, giving radiotherapy, it's not as simple as just writing up how much you're going to give, where you're going to give it to. We have to think about the side effects and then think about what we're going to give to help those too. So like somebody said earlier about the side effects of some treatments, I think that keep all of that in mind. It's all about the bigger picture. Very briefly, I'm going to talk about a few different types of radiotherapy. this is something I had to look up and talk to Dr. Lane about before doing this presentation. So this is stuff that's high level and you wouldn't be expected to know about it, but it's just interesting to understand how it kind of works. So don't really worry too much about the names, but in broad terms, you've got photon therapy and proton therapy, and then you've got IMRT, which is intensity modulated, so that's literally what it says in the tin, they modulate the intensity of the radiation, and then brachytherapy. Now, what the key thing I want you to think about is the delivery in terms of external or internal. So external is that picture we had on the very first slide of someone going into that machine and the radiotherapy is coming at them, and that causes the skin reactions. So obviously it has to go through the skin. Internal is when you actually put something in to the body that then emits the radiation from it. So it might be quite deep in the body, or it might be somewhere that's difficult to get to without affecting other organs from going outside in. The units is grey. You don't need to know that, but what's interesting is it's 1 joule absorbed per kilogram, so it's energy being absorbed into the body. I think that's just something to get your head around. So this is brachytherapy, quite an extravagant diagram, but this is being used to essentially inject these. So you can see up there the little metal parts, it's next to a coin to kind of show you, but they're injecting these forms of metal that then emit radiation, and it allows us to put it into somewhere that's quite deep. So in this case, they're using it to treat prostate cancer. And the reason they might use this is because the prostate, around it, are quite a lot of really important structures. So you don't really want to have side effects to your bladder, because that can be really, really difficult for your future life. You don't want to have other side effects around that area, because it affects things that can really be quite intolerable to people. And so this is an idea of how we can try and not damage the organs to get to the one that's deeper within it. Does that make sense? And then just thinking about photon or proton therapy, broadly what you need to keep in mind is photon therapy is the one that you probably have heard people have had. It's the common one. And what it does is, the difference between photon and proton is really about the energy load that they're putting in to the area. So if we can imagine we're treating a breast cancer, so we're going to be wanting to treat quite a large area as such, and also we're trying to treat, if we can imagine the tumour, you want to get the residual cells around it. So you don't want to miss anything on the edges, because that could then either spread or grow back in the same place. So photon therapy is quite good about giving a load that has quite a wide shadow, is what they call it. And all that means is that the radiation is going a bit further and beyond the initial centre of where you're targeting the energy. So you target the tumour in the breast, but there's a shadow around it quite a lot to get the areas that could also have a few cells residing there. Now that's fine, because if you think about where the breast is, if you're going sort of out around it a little bit, you're not going to be targeting too many really difficult organs, because you can make sure that the radiotherapy doesn't go deep enough to affect, say, the heart or lungs that would be underneath it. So you can try your best to reduce the depth that it's going to. But in something like the eye, or another organ that's really small, you'd, like near the sort of mediastinum, which is you probably know from biology, but around there you'd have lots of things like your esophagus, your heart. So if you had an esophageal cancer and it was coming near the heart and different important vessels, you don't really want to be having this massive shadow affecting all these organs near it, because that produces loads of side effects, and even quite life-threatening side effects. If you damage the heart or the brain and the eye, that could be really important. So using proton therapy, it dumps a greater load of energy at a particular depth, but it doesn't cover much of the other area. So if you've got a small tumour in a place where important structures are around it, that's quite useful, because it means we don't have as many side effects. But it's not as useful in an area where we want to try and get rid of residual cells. So it's just quite interesting to think about the way they're acting. So it's the amount of energy they're giving and how big an area they're spreading it over. Does that make sense? And so radiotherapy planning is a bit more clinical. So if somebody's going to have radiotherapy, they'll have a radiotherapy planning session. So they'll have a simulation, imaging, and moulds. And what that means is they're getting the person getting loads of images to work out exactly where they're going to target this radiotherapy. And there's a very complicated computer program that they'll go in and line up exactly where the rays are going to go in order to prevent side effects. So they're trying to minimize the other structures affected. So they're trying to get the angles all right to stop that happening. And often the massive factor of that is keeping the person in the same position. So it's all well and good if you've got a computer program getting that perfectly lined up, and then the person just moves a little bit and then it's gone. And that's the point of the moulds, is they keep them in the right place. So often if someone's getting head and neck radiotherapy, they might have to have a mask, as you can see in this photo, but also they can have some body moulds that people might use as well. It's trying to keep them in the same place and target just the area we need to minimize side effects and get the best response. So that kind of gives you a summary. I hope that was